Okay, at this point, we are going to stop and ask some. Do you have any questions to ask our two experts? Peter, Laurie.
First of all, I see that...
Could you just identify yourself?
Sorry, Peter Young, anesthetist, Yan Chai. I see that it has been put up that the anesthetist can resort to emergency transfusion against the patient's refusal. Now, I know we're talking about minors, but in an adult, I would advise caution. Perhaps Alex can comment on Millet versus Schulman, 1990, Ontario Court of Appeal.
Okay, so the question here is about an adult.
Yeah, well, in fact, I think the thing is that's first of all, but the other thing is re-E, because Alex actually also mentioned about a child then growing into an adult. For people who know about E is a Jehovah's Witness who had leukemia, and he needed chemotherapy. And also during the chemotherapy, he needed transfusion. He was 15 3/4 or thereabouts. He was just short of 16, where there's the presumption in the 1969, whatever act it was, that he may be able to refuse. And that's what his parents thought about. Anyway, the courts forced him to have a transfusion. He had a remission. Then 3 years later, when he was 18, it came back again. He refused blood transfusion and died. And the Chief Justice, and the main person who wrote the opinion in re-E, Lord Justice Ward, I think it was, he began to have second thoughts about it because afterwards, you had this, the benefit of hindsight was then he had forced someone to have done an ungodly thing, and then he grew out of the age in which he could then intervene, and then he went his own way. Perhaps, Alex, you may.
You can comment, but I see these are two different issues. At the time he was a minor, we presume, or we may be reasonably correct to assume that he may not have his capacity to understand. So I think there are several cases, even in the UK, that are borderline. And as he becomes an adult, yeah, he exerts his own free choice as a moral agent.
Yeah, thank you. That's really the last point that I made, that while we are spending some time talking about how to deal with the issues of minor, it's just 2 or 3 years later that the minor turned into a free agent as an adult and could make decisions refusing life-sustaining treatment without controversy. And that's why we feel that for cases like Jehovah's Witnesses, there should be a sort of a policy to deal with them.
Yeah, but as Singh has said, the coercive impact of just being in a family with Jehovah's Witness was clearly evident on the girl. And therefore, I think the court will take a view that, may have to override the parent's decision and probably even disregard the mental capacity of the child, because they will then rely on the medical evidence. In fact, the mental capacity of a child doesn't even come into play. And I think that's something that has been, you picked up the apparent disagreement between the mom, and I think this is the sort of hidden coercive or the tremendous pressure effect that will impact on an individual's decision-making capacity, particularly if it is a child. And it happens even as an adult. So I think that's where this case really hinges on.
Actually, I could see a shape of a policy coming into being from the way that the medical team handled the affair, because it may well be the case that the policy is to have a very rather long counseling session for the patients to ensure that at the end of the day it's the doctors bearing the responsibility rather than the parents or the child or the adults who would not then have to go to make themselves dirty.
Okay, any questions from the students? Oh yeah, sure.
in this case, the mother finally signed the consent. But in case if the mother still strongly refused, and then the girl also have a strong faith and also refused to have blood transfusion, they both have the same opinion. So what to do with the anesthetist and the surgeon? Will you proceed for the surgery if they both strongly refused? This is an elective surgery. Elective surgery.
Yeah, Bobby.
Sorry for being late because today I was particularly busy. But there's no bravery in this. I think that we went through the same process very carefully. Yeah, but we cannot guarantee 100% that the patient would not need transfusion. That's for us. That's impossible. Yeah. Even 1%, half a percent is still a chance that the patient may lose the life without a transfusion. So I think that it's a situation where we have to have the consent. I think however long that process of explanation, we're trying to get them to understand, because I think that always, as in life, the situation always is more difficult than it looks. Yeah, because this patient, in fact, the scoliosis is not straightforward. Yeah, I think a lot of the straightforward cases, but we can kind of say a high percentage, but that we may not need transfusion. But this one, we may need to do some complex spinal osteotomy, and that adds a very high risk to this patient by needing transfusion. Yeah. So, but for us, I think Dr. Kwok and we worked through the case very well. Diligently or whatever is required or out of necessity, but we just have to work on it. Yeah, but we need consent for transfusion. I think even 0.5% is a chance. Yeah, for us, but I just cannot give a 100% guarantee.
Yeah, what CK is asking is that there's no consent, no availability. Would you say that, okay, let's go ahead and do the surgery, and when the anesthetist said, it's life-threatening, get blood and do it. But protected in law, because or are we not? Yeah, will you go for a surgery without consent?
I think this case is not the life-threatening condition. Yeah, the patient will get problem, but later on, say 20 years later, 30 years later, when the curve gets higher and higher and higher, yeah, and then the patient will suffer, yeah, and at that point in time, with even higher risk for going through surgery, yeah. So I think for us, it's not a life and death situation. I think if it's a life and death situation where somebody come through the door, no chance, yeah, bleeding to death, but then we'll go ahead, yeah, just in that situation, but if somebody come in and say, well, okay, but he's a Jehovah Witness, yeah, then, well, I think for me, at that point in time, I probably would save a life and talk later kind of situation. Yeah, but not in this present case. Yeah.
That's great. Bobby's a good surgeon. He won't jump without a parachute.
Can the parents sue you for not giving treatment?
I think they have all the rights to do so. Yeah. But the only defense that you would have is that in the life and death situation, but
No. What you're saying is, can they sue you for not doing the surgery?
Doing the operation.
Not doing that. I don't think so. They have no grounds because they don't meet the conditions required for safe surgery. It's impossible. Okay, we'll continue with the case. Still more interesting things to come.
Well, I'm a male anesthetist, okay? So on that day, originally we have 3 anesthetists to patient, okay? 3 anesthetists to 2 patients, 1 mom and 1 patient, 1 resident, 1 consultant, 1 AC. And then somehow I missed my bet. I have a difficulty in asking the child to stay alone because I don't even know the child, the character. I don't know what to think. Okay, maybe it is too intimidated to see free anesthetist around her. But somehow the child created her own opportunity by crying and then sitting in the room refusing to leave when the mom go away with the church elder. And then we grab the child and then original 3-to-1, and then later we send her to another room with one female AC to one child, okay? More equal way to discussion. And then we understand, by that time we have more accurate view of the teenager view. She want, even on the first visit to us, she want to have the surgery soon, very much. Probably because of symptomatic, and also she is a smart girl. Actually, she has very good school results, so she wants to continue her school without interference. Okay, she say that not in front of her mom, that the mom want her to go to heaven than receiving blood. Okay, if there's a choice, the mom will want her to go to heaven. But the child herself accepted blood transfusion to save life because she also has friends who have scoliosis and say even her friend need blood transfusion. And she don't want to delay the decision to adult because her church will forgive children. But once she reach adult, the church will not forgive her. Okay? We call this the child benefit. We call this 兒童優惠, okay? Obviously, the teenager have some emotional distress, okay? The outcome was that we have arranged totally free pre-op visit, pre-op anesthesia clinic, and also asked the child to, initially, somehow we grab Dr. Singh into the water because we call different pediatricians and no one interested. And we call Zhong Hui. She is famous for difficult cases, metabolic disease, but she say Dr. Singh is better. And then after free visit, the mom finally agreed to sign the consent. We specified her hand is trembling because a lot of reluctancy, a lot of internal struggle to sign the consent. 3 times she failed, almost reached the pen, reached the paper. That's I can't. Let me think about it. And then the eventually signed the consent with reluctancy, with external manifestation of her reluctancy. So I think when Professor Kumta said the key point is ultra-major surgery without consent to blood transfusion, I think the key point is ultra-major surgery without consent but blood transfusion in a minor. That if it's an adult, it's less controversial. And I only need to call some sick leave during the case, okay? Then we'll be okay.
Okay. 3 important ethical legal issues.
Yeah, I want to explain the first question a little bit more. Because when the parent, because when we are anesthetists, we study a little bit of Jehovah Witness during our college exam, okay? Some Jehovah Witness refuse cell saver, actually. Cell saver is a technique that when the blood collected during the bleeding, okay, they put in the bottle and then later filter and then wash it and then save in a bag, wait for a few hours and then retransfuse to patient. And then on that day, all the church elder family say, we will agree but cell saver. Our approach is that we decide not to further explain anything about it. Because we are worried that if they understand the blood actually discontinue from the patient a little bit for a few hours, they will refuse. But why bother to explain something? And they look confident. They look confident. They seem to understand what is cell saver. So we never explain any single word on cell saver because they already agree. We don't want to create our own trouble. Now, whether this is the correct way, is it I'm trying to hiding something, I'm not sure, but this is the question.
Okay. I think 10 years ago, there was a survey made in the US. Who are the people who lie the most? First, number one is your relatives. They lie to you more. Number two, doctors. And number three, lawyers. But, lawyers, number three. Now, I think this is a very, very, very crucial ethical point about lying. And I think we definitely need to penetrate this. So let's vote again. Should we not disclose details of cell-saver autotransfusion? Those who agree should put the green. That means we should lie. Put up the green card. Those who say we should disclose, the other way. So who agrees that we should not disclose? Should not disclose.
They already agree.
No, we'll come to that. We'll let you elaborate. So I see a lot of people are not voting. So is it let me put it in another way. Is it acceptable to not completely explain the cell-saver process? In other words, it's a kind of white lie. Do you think it's acceptable to do that? Okay, so some red, some green. Question 2. Is it reasonable and ethical to give blood transfusion as and when necessary on life-saving grounds in this patient or in a Jehovah's Witness patient, but not to disclose it? No, you don't want to lie. But on the first one, many of you said it's okay to lie. No. I think Dr. Kwok, normally surgeons are very good at lying, but here I find the anesthetist defending lies very well. So we'll give him a chance. Okay, I think it's important, not disclosure, and we discussed this in the first ethics workshop about disclosure. Not disclosing and telling something false are the same. It's a lie. And if you see amongst the 7 ethical domains, truthfulness, and the standard for truthfulness is absolute truthfulness in medicine, because surely it's easy to find out what happens in a cell saver. The internet is full of information, and therefore I think we have to be careful about, if we don't disclose information, doesn't mean information is not accessible. The third question again, I think that was asked, is it ethical to withhold elective treatment if patient and parents do not comply with doctor's advice on matters of life and death? Yeah, I think it's pretty straightforward. And I think the rule of this is ethics precedes legality, and therefore if things are ethically correct, the legal issues are less likely to be prevalent. So I'm going to ask now the clinical expert views. First, Simon, should we disclose details of cell saver? You're an expert in the cell saver. Or should you not disclose?
I think this is a relatively easy question to me, because being the believer of the Jehovah's Witness, they will have all the information about what to accept, not what to accept, and has been guided by the church elder. So I don't. Well, from our point of view, actually from my point of view, if they already accept the cell saver, and on the assumption that they have the full information about what cell saver is, so I do not go through the detail of the cell savers.
But I assume full information was given about cell saver, or not given?
The church elder, they have a full document. They say they accept cell saver. It's fair, no controversy. But the controversy is in our heart. We are not sure they really understand what cell saver. But this is just a conspiracy. Maybe they understand. They know many things. They know erythropoietin. They know many success stories of how to. So maybe it's my concept is wrong. So it's just more personal level. I think they look very confident. They understand this is acceptable. So why bother further explanation?
And somehow the church have construct a theory to make it acceptable to all the believers because they would sort of, they're still in the continuity of the bloodstream.
Okay, so we should be as explicit as possible to a reasonable level of understanding without hiding information as far as cell saver. And if they've accepted it, I think it's pretty okay.
Yeah.
So we asked the parents whether they would like the doctor to explain to them what the cell saver is. Because we have the opportunity to let the parents to decide whether they want to learn more about it or not. Because we are not going to explain all the great details, but they have the choice to listen or not or to listen. But you still check, do you want to listen to my explanation? If they say, no, I know everything, then that's fine.
They trust their church.
Yeah, I think you're just inviting troubles.
Okay, so the least possible complete information that is not likely to confuse them further and not likely to jeopardize the consent is what the approach has been used, and I think that's reasonable. Do you have any questions to ask at this point? Okay. Actually, my screen turned off here. So I think, Alex, can you just turn this on? Yeah. Yeah, sure.
So my understanding of informed consent is that for any procedure is that you have to kind of lay out what the procedure would be. And so, so if I am a little confused why in this instance you wouldn't talk about like the details.
What was the question?
Completely transparent.
Yeah.
You have to explain all the trick and the detail for patients.
You get an award for this question. Congratulations.
I know, and I understand that from a sort of a medical point of view, that we have to explain all detailed procedures to all the patient if they raise the questions. In clinical practice, we don't know how much the patient or the parents would need to know the information. So in other words, when we are offering the information, we will have to see how much information they would like to receive. Some of the patients, they would just refuse to take information. So some patients will just say, please go ahead, you have all my trust. So in that case, you would not give all the information. Whereas some other patients, they would like to have all the single piece of information, and they will ask the question. Then you would disclose all the information in relation to that particular procedures. So in other words, the information transfer to the patients would depend on how much they want to receive. Got it?
Actually, we discussed this in the first clinical workshop with James Badenoch, and this is regarding the Montgomery case, following which a lot of the views on informed consent have been revisited. I think there is a reasonable requirement, especially to explain risks that might be reasonably manifest so that the patient understands or the relatives understand the magnitude of the risk. And the explanation of other processes should be reasonable enough for them to understand and make an informed choice. Now, the question of this, what is reasonable, will still be, if it goes to the courts, good luck. But if you agree, then like most of us, we convey complicated information about spinal surgery or limb salvage, etc. And the explanation is reasonable. It doesn't have to be technical. So,
well, I really think that in clinical practice that we're trying to give as much information as possible to the patients if they ask for. And that's why we all, in order to help us, there is a pamphlet or information sheet hand over to the patient that the procedures that we are doing, like the pain procedure that we're doing, we all have a list of all the indication, alternative, what is the risk, and also what's the benefit, and how to take care about after the post-operative procedures. All the information will be given to the patient, and if they have any specific question, they can ask. Now, for this particular case, whether we would have to disclose about the autologous blood transfusion. Now, for this particular case, cell saver, not autologous blood transfusion. For this particular case, the patient and also the parents, as well as the church elders, has already said they would accept the cell savers, which is, to our understanding, they already have a full understanding of what is this particular cell savers about, and they would have gone through a very stringent procedure to make it allowed in their church. And that's why I do not think that it's unnecessary to go through that again for that reason.
Yeah, see.
I think for the informed consent, we certainly have to disclose to the patient and the family about the risk of the operation, of the procedure. For example, what are the risks of the cell saver, for example? I don't know very well. Is that thrombosis or something like that? The clot formation. I think this should be disclosed to the parents. But about the details of the procedure, just like a surgeon, if they're operating on the scoliosis, I don't think Bobby will be like teaching a medical student or resident exactly how details these operations will be done. I don't think that is necessary. That is not necessary. But the risk of the procedure should be disclosed to the patient or to the family.
Yep. One last question, and then we move on.
Well, actually, there's a comment on the informed consent aspects of it. I mean, I think, yes, a lot has changed with Montgomery, but I think in that particular case, Montgomery asked a question of the particular obstetrician, and it was just fobbed off, and I think that was slightly different. Some things are particularly important to certain patients, and I remember, for example, in my practice, one patient asked me, can you avoid putting a tube into my throat whilst you turn me upside down, well, I mean, turn me the other way, face down, so that you can harvest my bone marrow? It was important to her because she sings, she's a soprano, and she sings, and she had been reading, Jose Carrera's thing about, biography about how he got his bone marrow harvest. But I think that's one thing. The other thing is, I think it's also, it's also undesirable to actually go in a lot of minor details, something like sectionalized consent. I don't think it's a good idea if I ask, well, do you want thiopentin, do you want ketamine, or do you want propofol, or do you want something else, and list every single drug, because I think that actually is abrogating my responsibility and my judgment on what drug. Every drug has its good, bad, and not so good things about it, and that is my professional responsibility and my professional judgment to choose the drug which is best for the patient in front of me in the circumstances. And I don't think the informed consent need to go onto that level. If I do that, I think there is a sense of me actually shoving some of my responsibility onto the patient in the name of transparency, but in fact, I'm actually shoving responsibility onto the patient.
Very true. I think point well taken, and congratulations for that question. You can get another award if you want another one.
I don't want any award. So I feel like there are two parts to how you're addressing this. One is that, like, one is that the technical detail that you want to give, but I feel like in this instance, her understanding of self-saver is actually very important to her. In that, like, my understanding of informed consent is that you disclose complications that could be very important, like infertility, to a particular patient. And then another part is that you say, because she is part of this church, then you assume that she already understands. But like, this assumption, I think, is a very slippery slope for, like, does a normal adult male, like, understand? If he says, oh, I understand the complications of X surgery, will you just accept that? But I feel like in informed consent, you would still list through, like, your standard kind of complication list.
Okay, so actually she makes a good point. So the moot question is, should we tell the parents that the blood actually leaves the body, goes there and comes back? Because that is the issue. And I think I take your point. I think that's correct. But I think we can argue over wine and cheese outside, because otherwise we won't finish. But it's a good thing. The element of informed consent in this particular case may require further elaboration of the cell saver. We may choose to agree or disagree, but I think I really congratulate you for raising this. I'm going to actually skip over this because Alexandra has already touched. The question is, under what circumstances it is lawful to carry out some form of treatment without the consent of a child, of course, life-threatening, etc. So I'm going to move past because we're getting late. A Q&A from the audience. We've already had a brief discussion on the surgeon versus the anesthetist, and again, that's also been resolved. And I think Bobby has explained that occasionally you may, particularly an adult patient, in terms of emergency, go ahead. But in an elective situation, he has already said he would not go ahead with major surgery without consent for blood transfusion. So I'm going to skip this as well. And I'm going to ask WH to explain finally what happened.
Well, finally, we proceed to elective surgery. I didn't take a sick leave because Amy Chow, my boss, tell me, Dr. Kok, you are the anesthetist, okay. No one will anesthetize this patient if you got sick leave, okay. The patient will cancel. So I say, okay. So I'm the person. I'm chosen one, okay. So we change our anesthetic a little bit to, we call it hypotensive technique, but actually a little bit lower than usual. Hopefully it will reduce blood loss, but the evidence is not strong actually. We use some drug called transamine, which is proven to reduce some blood transfusion requirement. And finally, the surgeon find that in drop, the spine is not very rigid, and think that the curve can be corrected without an osteotomy that actually reduce blood loss. And also, interestingly, the cell saver blood, despite some blood loss, okay, the cell saver blood, after washing, they remove all the damaged red cell, return 1 ml in the dead space. We cannot retransfuse any blood back to the patient. It's technical side of cell saver, which we seldom have this problem, but somehow in this patient it happened. So sometimes the cell is smaller than usual, or some of the patients have thalassemia, or sometimes the cell during the suction is broken. The cell saver actually remove it. I think this is not a normal cell, so they actually only 1 cc of blood can be reproduced by the cell saver. And no blood transfusion was needed, and lowest hemoglobin was 8.8 grams per deciliter. The mom and patient are very pleased with the outcome. And they are extremely grateful and try to call me several times to come to thank me, okay, give me a card, okay. And this is my point of view. I feel that if the fact we give blood, though even though they sign the consent for blood transfusion, they will have very strong grief or emotional distress because they think they still have a strong faith and they may feel that their body has been violated, they may feel that they will have to go to hell. So this is the outcome. I think with some luck, there's some luck element, but this may not be reproducible every time.
So there's still a risk to use cell saver because you can't transfuse. So if you really needed transfusion, you would be, there would not be any blood in the cell saver. Then what would you have done? Then you would have had to give blood. Okay, I think, Bobby, how's the patient doing?
As a life would have it, but somehow I bumped into the patient yesterday in the lift. She came back to follow up, and she was very, very grateful. Yeah. For me, I think the Jehovah Witness patient I have treated in the past. Yeah, they're extremely nice people, marvelous people, very, very kind, very, very understandable. Yeah. I think I go with the person who asked that question. But for me, the informed consent is, I would tell them everything, yeah. Because for me, there's no holdback, yeah. But I have a duty to tell them, but this is it. But we would use the cell saver, and we would take the blood to filter it, but resuspend it in the solution and transfuse, yeah. But as in this occasion, I think for me, most of the work has been done. On this case, to me, the most important part is teamwork. Yeah, the whole team will need to work together. We have to work very hard. Yeah, and you have to kind of go through. But sometimes you will have this feeling why the people will have such a strange belief. Yeah, I think maybe our belief can be strange for them. Yeah, but I think when you need to come to this situation, the teamwork is very important. We'll work very hard. But to me, sometimes. All the time is when you work very hard, yeah, prepare everything, yeah, because if we prepare that, we probably need to transfuse, and we need to take the brunt of the difficulty to handle the parents afterwards, yeah. And I think if we come to that situation, I don't think we would hold back. We will transfuse and we'll take the brunt. Yeah.
Thanks very much. So finally, you still have Q&A if you want. I think there are some important things about faith-based decisions and how we should respond. Without a doubt, we should respect individual autonomy, and particularly if in adults, and we discussed the issue in a child, autonomy supersedes other concerns, however sound and rational and scientific they may be. It's a patient's choice. You might want to treat him in a particular way, but doesn't want. I think faith-based decisions are irrational because faith is irrational. There is no rationality in faith. That's the very nature of faith. So it's impossible to convince people to change their faith because it takes time. We as doctors are obliged to respect faith-based decisions, no matter how stupid, silly, terrible they may appear to be. Because do not underestimate the failure to disrespect that causes severe distress to people and their families, and it can impair relations forever. So that's something we don't hear of. However, we are not obliged to follow or pursue interventions that are demanded on the basis of faith in which obvious harms might occur, like mutilations and unindicated organ removals and hormonal therapy. You will be surprised if you look at the literature of what has happened, and if you look at history, blindnings for converting people into not professional beggars, but religious beggars, amputations for begging outside temples and mosques, castrations, hysterectomies for so-called sexual promiscuity, for being rich. the development history of how eunuchs came into the court. If you actually read medieval and ancient Indian and Chinese history, they were barbers and doctors who produced eunuchs because it was considered an important. So faith-based decision when it comes to minors, I think that's something, it's very important. And one should understand the triangular relationship between the freedom of religion on one hand, parental responsibility and discretion, because the parents are the guardians of the child. But on top of these two sits the professional and societal obligation to protect vulnerable children and minors. And therefore, when professionals identify a child who faces danger, death, or disability because of parents' decisions, actions, or inactions, as it may be, they are obligated not only by professional standards, but also protected by law to report the situation to the proper authorities and to act upon it. And therefore, in situations of imminent danger to the child, it is ethically justified and you are legally protected for healthcare professionals to proceed with life-saving. And this is it from the UK common law, and I believe the situation is identical in Hong Kong as well. And there is wide consensus in the medical profession, I should write in brackets, I hope, and in the courts that even caring parents should not be allowed to refuse life or limb-saving medications, transfusions, or procedures. Yet you will see, if you look at the literature in the US, there are several states that override these, and there are lots of case reports of children being allowed to die because of beliefs in miracles and alternative treatments in the situation of life-threatening illnesses. So, final Q&A. Any questions from our experts? Oh yeah, sure. Questions, comments?
Kunta, congratulations for a very, very stimulating, very challenging. And these are sort of conversations we need to conduct. Sorry. I actually look at this from a slightly different angle, as you know, my role as the patient relations and other things. I think the learning point for me was so crucial that the key solution to all this is communication, good communication. Understand what is really behind everything. What is the position of the patient or the family may not be their interest. We really need to dig enough and explore options. That's the way forward, not going to court. Really, really talk to your patients and family.
Absolutely. I think WH is, the way they conduct it, and I think his first statement has been non-antagonist. So maybe WH, you want to...
Final comment from me is that just say the refusal of blood transfusion form, someone regard it as a life and death contract, okay? But a consent form to blood transfusion in this case should not be viewed as absolute right to blood transfusion. And because when they should sign the transfusion form, consent form for the operation, they have the trust on us that we will try our best not to give transfusion. We only use this as a final tool. And we should not view this form as, okay, we can give blood transfusion, don't worry about it, okay? But we will try our best to lower our transfusion threshold a little bit within the safety limit and not to deliberate. But this is a trust built upon several visits. They trust us, we'll try our best not to give blood. But so we should not use this as a tool, say, as a defensive medicine, just to give blood more liberally than usual. So this my point is a trust between the finally we have successfully built a trust between the medical side and the patient side.
May I ask another scenario? Let's say if the mom still refuses to sign the consent for blood transfusion, but if the daughter, the minor, that she so decided to sign the consent for blood transfusion, what will be the surgeons and anesthetists will do if the mother still refuses, but the minor patient consent, according to the GLIC's competence, she should be, but however, the mother is still the guardian. She refused.
Thanks, Dr. Lee. Yeah, I think there are case law which supports the decision for minors to minors' decisions to override the parents' decision, even for children which are sort of younger than 16. I think the courts are quite prepared to lower the age from 16 to 15 to 14, but maybe not under 12 as it was stated, because nowadays I think children have grown to be a lot more mature. They are also exposed to a lot of information. I would still think that there is a pro-life approach in the courts.
Yeah, pro-life, prevention of disability, and I think they must be weightage put on what is the underlying, surgical need, if it's significant enough, and if it's in the interest of the child to get it done with. I think they can override parental objections.
Do we need to apply for the court order?
Yes, otherwise it's battery.
I would encourage it. And I think also in some countries, like in the States, the parents might actually initiate a fight if they see that the doctors are trying to do something to the child they do not disagree with. I think the parents can be a bit belligerent in these situations, so one have to be careful about it.
I think coming back to the English law situation, I remember, I think it was Donaldson, LJ, who actually said that in fact either of them will do. If you could have a consent from a minor or a consent from a parent, in fact it works anyway. It talks about flak jackets and all sorts of things. I can't remember which court case it was, but in fact either the minor's consent or the parent's consent, if there's one but not the other, it will already authorize treatment, and it's just like,
It's in the Gillick case that's there, because the Gillick case has the first case and then the appeal and the appeal turnover. So it's in the substance of that there's quite a lot of discussion. But in Hong Kong, you still need to get a court order, because operating on a minor without parental consent will still be battery.
Actually, I disagree, but in the sense that this is after all elective surgery. Even those who have some limb numbness, still have no cord compression, I doubt we can apply court order very much if the child wants to do the surgery. And at the conclusion, we should not break the family. And at the end, I think if the court asks Bobby, is the surgery we needed now, can we wait for a few years? I doubt Bobby will say, can't wait.
It actually depends. If you get two surgeons to say that, what if you get incontinence? They're finished. So the court will say, okay, do the surgery tomorrow.
Okay. But you are giving selected effect.
Well, I mean, look at a 14-year-old child with scoliosis and has developed numbness. I think impending neurology is something that would be, I would be worried if I am having numbness and I know it's going to progress. So, yeah, there's somebody else wanted a question, and then Alexandra. Yeah.
I'm not the question, but just follow the question, because I'm an OT nurse and also work in the POAC. That I'm lucky to encounter this case. So the question, the key issue is really the mother didn't want to have the surgery, but the doctor really want to have. So we just put them on the same ground, that the mother loved the doctor, and the doctor really loved the mother. So we try to use some mediation skills to let them to talk together until they get the consensus, and then they sign, even though the mother really reluctant to do sign the consent.
Oh, that's the best case scenario, but what if it doesn't? And that's what we are discussing. If it doesn't happen, then...
So I think if in another situation, if the mother really don't want to have it and the doctor really want to have the surgery, from my point of view, just Dr. Cox said, we don't want to break the family. So we just let them to have the consent.
You don't want to break the family, but you wouldn't mind the daughter becoming paralyzed, incontinent,
I think
neurologically impaired, disabled, functionally.
So that's why we need to talk about.
You have to challenge me.
We need to talk about it to the mother, whether you love the doctor, because I can understand how the mother loved the doctors because she want her to go to heaven instead of hell. But on the other ground, now we are still on the earth, and then we are still have the life, and then how can match them?
Actually, there are several cases in the US court jurisdiction where extremely loving parents have said they love their child so much that they want the child to go to heaven. And I think that's so, you know, these emotional issues need to be separated because I think if the child wants surgery and the parents are refusing, the question is, are we ethically and legally mandated to go ahead? And I think that is a decision that the chief surgeon will make on the risk, on the benefit, on how. Maybe Bobby, you would like to elaborate.
Yeah. I think that they're very careful. But in fact, my mother wants her to have surgery. Yeah, surgery definitely yes, but just no transfusion. Yeah, but for me, at the end of the day, I learned from this case. Most important is what Dr. Lewis said. It's communication. Yeah, and what I do is I have responsibility. Yeah. And I feel very strongly, but the person just asked that question about informed consent, yeah? So I tell them everything, yeah? And what I want to do from that process, yeah, is what I tell them is because I want them to be on my side, okay? I want them to be on my side, but I mean, what are you going to do? But imagine you are the surgeon, yeah? And you know if something happened, but we don't transfuse, that person is going to die. Would you be able to say, but you would not give transfusion? Basically, but this is how I work on this case. Yeah, it's about communication. You tell them what your situation is. Yeah, and they would need to understand, and be on my side, and that's how I best will handle this situation. Yeah.
Okay, I think it's getting to the end of the day. I want to thank all of you for attending, and I want to thank all our panel members. I have one small announcement to make. If you're an adult and not a medical student, please stop by for wine.